Good morning, everyone. Today I will be presenting approach to pH positive ALL in adults. Um, so, uh, so I'll be covering the topics under the following headings, which are enlisted over here. So, pH positive ALL in the WHO 2016 classification comes under the heading under the subheading of B lymphoblastic leukemia lymphoma with recurrent genetic abnormalities. This is a very common amongst the patients with acute lymphoblastic leukemia. This is the incidence of pH positive ALL actually increases with the age. So the incidence which is seen in adults is much more than what is seen in children. In adults, the incidence of pH positive ALL is 25%, whereas in children it is 2 to 4%. In addition to that, as the age of the patients increase, the incidence of pH positive ALL also increases. So much so that at more than 50 years of age, the occurrence of pH positive, the incidence of pH positive ALL is 50% amongst the patients who are diagnosed with ALL. pH positive ALL historically has been considered to be aggressive form of all the leukemias, with characterized clinically by high WBC count, has increased risk of CNS involvement with aggressive clinical course and inferior outcome. The establishment of the diagnosis of pH positive ALL becomes of paramount importance in the treatment, because we would be able to initiate patient on directed therapy once the diagnosis is established. So the diagnostic test which would help us identify whether a particular patient is having pH positive ALL, the first one being the flow cytometry. In the flow cytometry, the most important identifying factor would be to first identify whether the particular involved blasts are of B cell lineage, which we could identify with the B cell markers, which is CD19, CD79A, and CD22, and then presence of myeloid associated antigens like CD13 and 33, and presence of CD25. These are, if we find a flow cytometry report with these findings, we could predict that the patient would most likely be having pH positive ALL. The diagnostic confirmation of pH positive ALL is by demonstrating the translocation using FISH and conventional karyotype, and then subsequently we also need to identify the transcript type. Now, the identification of the transcript type is of importance because it helps us to monitor the disease later on. The transcript type can be P190 as well as P210. P210, as we know, is the transcript type which is seen in CML. P190 is the transcript type which is commonly associated with pH positive ALL. But in adults, there are still almost one-third of the patients who can, one-third of the patients with pH positive ALL who can be P210. Now, one of the close differentials which comes in the regular clinical practice is is to differentiate the pH positive ALL from CML lymphoid blast crisis. Why is it important to differentiate? Because the disease entity is completely different, treatment is completely different, and the prognosis is completely different. So, so differentiating that becomes of paramount importance. But at times, this differentiation might not be that that straightforward. So there are certain clinical features in the patients, clinical features and laboratory features in the patients, which would help us to say that it is more that this particular patient might be having CML lymphoid crisis more than pH positive ALL. This could be that patient has a past history of CML, or patient has a massive splenomegaly. pH positive ALL patients could characteristically don't have massive splenomegaly like that of the CML patients. Presence of basophilia in the peripheral smear or the bone marrow smear. P210 transcript presence, which is more commonly associated with CML, and evidence of clonal evolution. So please note, presence of P210 transcript does not make it CML blast crisis. One third of the patients with pH positive ALL still can have P210 transcript. So all these factors would favor a diagnosis of CML lymphoid blast crisis. So in a patient whom we are suspecting pH positive ALL, one of the close differential is CML lymphoid blast crisis, and this differentiation should be confirmed. Another important thing which comes in the treatment while in the treatment of pH positive ALL patients is the development of different mutations. As we know, we are using different TKs during the therapy, and patients invariably end up developing mutations. So assessment of mutational analysis is also has also become part and parcel of the treatment evaluation. So mutational analysis, if we what we need to understand is that when we have in pH positive ALL patients, if we use a very sensitive method to check for mutations, we might end up finding low level kinase domain mutations even at diagnosis, but its relevance is unclear. So this was actually characterized in this particular trial, which is mentioned on the left hand side, where they looked at 15 patients with pH positive ALL whose mutations were assessed at the baseline. Kinase domain mutations were assessed at the baseline, and they found that all the patients had some form of kinase domain mutation at baseline itself, and so much so that each patient had 2 to 8 mutations. But despite the presence of mutations, 7 patients remained in remission and 8 patients relapsed. So the identification of this mutation at baseline may not be of relevance. So mutational analysis should not be carried out at baseline. It should be carried out only if there is lack of response, or there is a rising MRD, or if there is a overt relapse. So going on, so I'll be going on into the treatment protocol. So treatment protocol for patients with pH positive ALL. First, I would be broadly describing the treatment principle, and then I will be going into the different treatment modalities which are available. So as we know, the ALL treatment has evolved over the last 6 to 7 decades, from single agent chemotherapy to multi-agent chemotherapy. So in the adults, initially people used to use adult protocol, but of late the pediatric inspired protocol has been found to have better results than the adult protocol. All the trials which are mentioned in the in this particular presentation would either use pediatric inspired protocol or the adult protocol, depending on the institutions from where the trial was conducted. Nevertheless, the chemotherapy backbone could be either of these. So the pH positive ALL treatment, if we see before the introduction of tyrosine kinase inhibitors, was with the help of chemotherapy alone, and chemotherapy which could be either a pediatric inspired protocol or the adult protocol. And in that duration, in that time period when only chemotherapy was used, the outcomes were dismal. We see that with chemotherapy, the survival at 5 years was less than 20%. And these are all the trials in the pre-chemotherapy era, which is showing the OS, which is in months. and less than 20 percentage. So this was the whole reason why Ph positive ALL was considered as a poor prognosis disease. But then things started to change with two major interventions. First is allogeneic stem cell transplant. The second is identification of tyrosine kinase inhibitors. So the allogeneic stem cell transplant was utilized in the pre-TKI era itself, and the first trial, which one of the earliest trials which presented the data of allogeneic stem cell transplant was the MRC UK ALL trial. This was in the pre-imatinib era, where Ph positive ALL patients received chemotherapy, and those patients who were in CR were assessed for availability of donor. If the sibling donor was available, the patient's sibling donor or a matched unrelated donor was available, patient underwent allogeneic transplant. If a donor was not available, they received either chemotherapy or autologous transplant. Most of the patients received chemotherapy, and there were 262 patients. Only 167 patients achieved CR, which was a 67% of the total patients achieved CR. And at 5 years, the overall survival in the allogeneic stem cell transplant patients who underwent allogeneic stem cell transplant was 44%. Overall survival for patients who underwent mud transplant was 36%, and overall survival for chemotherapy alone was 19%. So the transplant had improved the outcomes in these patients. But this graph is not giving us a complete picture. What we need to remember is that even though 67% achieved CR, only 76 patients, which is only 28% of the whole population, underwent transplant. Why they didn't undergo transplant? One because patients were unfit or elderly. Almost 19 patients were unfit or elderly. Before undergoing transplant, 37 patients actually progressed, and there was non-availability of donor in only 45 patients. So almost half the patients had progressed before undergoing transplant. So if we see the donor no donor survival analysis, we find that even though in those patients who had a donor, the 5-year survival is 34%. So this graph only looks at the small subset of patients who had undergone sibling allogeneic stem cell transplant and mud allogeneic stem cell transplant. But then the actual picture is that not all are able to reach till transplant. So things started to change with the knowledge that Ph positive ALL can be targeted with TKI, and UK ALL MRC group itself continued this particular trial, which I had mentioned, by adding imatinib to the treatment. So the treatment protocol which I mentioned before, they just modified it by adding imatinib to it, and what they found was that imatinib just changed the whole picture. Imatinib improved the CHR rate from 82 to 92%. The EFS, which was 18%, became 33%. The OS, which was 22%, became 38%. And the other point which came up was, whereas in the previous trial, 28%, only 28% could undergo transplant. Here, 60% could undergo transplant. Thus, imatinib helped in maintaining the remission till the medium time of stem cell transplant. So, if we look at the overall treatment outline of the patients from the studies which I have presented, all the patients should get a tyrosine kinase inhibitor with chemotherapy backbone. If they are in CR, they should undergo allogeneic stem cell transplant, provided the patient is fit and a donor is available. Obviously, with the development of further generations of TKI, other TKIs were also used in the therapeutic armamentarium. So dasatinib, bosutinib, and nilotinib, dasatinib, and ponatinib were also used in these patients in the later trials. Before moving further, two important aspects which I want to cover is, first one is the role of role of CNS therapy. So, as we know, in ALL patients, patients can have occult disease in the CNS. So, CNS therapy becomes part and parcel of the treatment. All the treatment protocols have CNS therapy included in it. The TKs which we use, imatinib, nilotinib, dasatinib, and ponatinib, also has CNS activity. Imatinib and nilotinib does not cross the blood-brain barrier, so it does not have the CNS activity. Whereas dasatinib and ponatinib crosses the blood-brain barrier, and they have CNS activity. The autologous stem cell transplant, which is used, if myeloablative autologous stem cell transplant is used, TVA is inbuilt in it. That also has CNS activity. But the problem comes in because over the recent years, with the use of reduced intensity conditioning and with the use of chemotherapy-free regimens, we end up compromising the prophylactic CNS therapy. So we must always keep in mind that patients that we administer adequate amounts of CNS therapy in the form of methotrexate and high dose methotrexate. So that is one important aspect of the treatment which should be considered. Other aspect which I wanted to cover was when should we add the TK? So tyrosine kinase inhibitor, which is imatinib, was assessed whether it could be added in a concurrent fashion or a sequential fashion, and this was studied in the GMOL by the GMOL group, and what they found was that concurrent administration, that is administration of TK along with the chemotherapy, resulted in better CR rates and better depth of response, and concurrent administration is the accepted standard. So TK plus chemotherapy backbone, which chemotherapy backbone is the backbone of treatment, that is the induction and the consolidation, and then if the patient is in CR, they should undergo transplant. The TK which we can use is imatinib, dasatinib, nilotinib, and ponatinib. Imatinib, dasatinib, nilotinib, and ponatinib all can be used concurrent with the chemotherapy, and CNS therapy also should be given in addition to the TK and the chemotherapy. Now, with the improved efficacy imparted by the tyrosine kinase inhibitor, another aspect of the treatment which came in was the reduction of the chemotherapy, because chemotherapy by itself was toxic, resulting in a lot of treatment related mortalities and induction mortalities. So the other aspect which was looked into was whether the chemotherapy intensity could be reduced. So the further studies which I would be mentioning would be covering the topic in 3 headings: whether intensive chemotherapy plus TKI can be given, or low dose chemotherapy plus TKI can be given, or steroid plus TKI can be given. So intensive chemotherapy plus TKI was the initial strategy which was used for all the patients. The MRC trial which I had mentioned utilized intensive chemotherapy plus TKI approach. With dasatinib also, an intensive chemotherapy plus TKI approach was used by the MD Anderson group, where they gave hyper CVAD along with dasatinib. The induction and consolidation with hyper CVAD was given, and those patients who had a donor, patients underwent transplant, and those who did not have donor received maintenance. These patients were more than 18 years of age, and the CR rates were 96%, and the OS rate had improved to 65 to 70%. Similarly, with nilotinib, they used intensive chemotherapy plus nilotinib approach. And they found that the CR rates were 90%, and the OS had improved to up to 70%. As I had mentioned before, one of the major hindrances in therapy is the development of mutations, and with the use of second generation TKI, first generation and second generation TKI, patients invariably end up developing mutations. This is an analysis of the patients who had undergone, who had developed relapse, And what they found is that amongst the patients who had relapsed, almost half of them had a T315I mutation. So T315I mutation makes the patient resistant to all the due to the first generation as well as the second generation TK. So this pushed the investigators to look at the role of third generation TK, which is not resistant to any of the TKs, any of the mutations mentioned above. And this was studied by the MD Anderson group again, which looked at the role of hyperCVAD with ponatinib, and they found that the CR rate was almost 100% with an OS 5-year OS of 74%. So now we comparing all the trials, all the intensive chemotherapy plus TK trials. What we find is that the CR rates are all similar, whether we use imatinib, dasatinib, nilotinib, or ponatinib. It ranges from 90 to 100. But as we use more potent TK, the relapse-free survival and the OS improves improves considerably. Does that mean that the second and third generation TK is superior to the first generation TK? There have not no head-to-head comparisons have been done between the TKs to establish the same. However, there are meta-analysis and a propensity score analysis which has shown that use of ponatinib is much more superior to use of first generation or second generation TK in terms of the overall survival, in terms of the molecular response, overall event-free survival, and the overall survival. So going on to the treatment. So in summary, ponatinib is better in comparison to the first generation and second generation TK. Now, as I mentioned before, the use of intensive chemotherapy plus TK becomes a problem in these patients because most of these patients are elderly and they are not able to tolerate intensive chemotherapy. And there is a lot of treatment related mortality because of the chemotherapy related toxicity. So the next approach which was looked in was to whether the intensity of the chemotherapy can be reduced, or whether chemotherapy itself could be avoided. So the first approach was to look at whether the intensity of the chemotherapy can be reduced. So this was looked in by the European Working Group, where there were two trials, the EVOL trials. The EVOL 1 trial used dasatinib. EVOL 2 trial used nilotinib, but the protocol is almost similar. The chemotherapy which they followed was either they used low dose chemotherapy in the form of vincristine dexa in the first month, and then intermediate dose methotrexate, L-asparagine, Araci in the consolidation. So what they found was that the CR rates were anyways similar, 90 to 100%, but the EFS, which was EFS and the OS were 30 to 40%. One thing which we need to bear in mind is that this was the population which was chosen where patients who were more than 55 years. The trials which I had mentioned before had younger population also. The other approach was to use steroid plus TK, that is not using any form of chemotherapy, only using steroid and tyrosine kinase inhibitor. So that was done by the GMIMA group. So where they used a steroid prephase followed by steroid plus imatinib. This was in the 0201B trial, where they found that the median OS was almost 20 months. The 1509 trial utilized steroid plus dasatinib, but here they tried to consolidate with some form of chemotherapy also. Hence, the EFS and the OS actually becomes better. And the GMIMA 1811 trial, where ponatinib was used, again we find that the EFS is 14 months. So these are the three approaches which I had summarized till now. What we find is that the CR rates are almost same. There's not much difference, but the RFS and the OS rate becomes different based on the chemotherapy backbone which we use. So there is no doubt that if we use intensive chemotherapy, the overall survival rate and the relapse-free survival becomes much more superior than the lower intensity chemotherapy or steroid. What we need to also remember that the stem cell transplant percentage also were different in these in these different groups of patients. The more intensive chemotherapy was used in the more stem cell transplant was used in patients who had received intensive chemotherapy and TK, but the stem cell transplant percentage was lesser in the patients who in the studies where lower intensity chemotherapy or steroids were used, because these were unfit patients to begin with. So in summary till now, what I had said is that ponatinib is better in comparison to imatinib, and amongst the chemotherapy options, all three options are suitable options, but intensive chemotherapy plus TKI results in the best results in terms of EFS and OS. Low dose chemotherapy and steroid plus TKI could be used in elderly, unfit, and frail patients. Now, till now, I had looked at the treatment in these two aspects. Now, we will look at the treatment in another aspect, whether we can modify the treatment based on the response the patient has developed. So that was assessed using the RQPCR minimal residual disease assessment. So as I had said that with the use of tyrosine kinase inhibitor, whether it is imatinib, nilotinib, or dasatinib, or ponatinib, the complete hematological response invariably reaches 90 to 100%. So a complete hematological response, achievement of complete hematological response does not impact the treatment later on. Now, what the minimal residual disease assessment can be done in patients, as we have seen in the Ph negative subgroup also. However, in Ph positive ALL, because of the availability of the 922 translocation, we can actually monitor the minimal residual disease using BCR-ABL transcript quantification. The other method of MRD monitoring is by looking at flow, NGS, and PCR. MRD monitoring using BCR-ABL transcript quantification is very technically straightforward, but the problem is that this particular MRD monitoring has been standardized for CML, but it's not been validated for Ph positive ALL. And the other issue is P190, which is more commonly found in Ph positive ALL, is less standardized than P210 transcript type. If we compare the MRD monitoring between RQPCR and the immunoglobulin TCR monitoring, what has been found is that the concordance between the two is only 70%. But the conclusion currently is that whenever possible, BCR-ABL should be monitored early. RQPCR BCR-ABL monitoring is more sensitive than the flow cytometry monitoring, and if we are able to monitor both, that would be the best scenario. Now, how do we modify treatment based on the response of the patient in terms of the RQPCR BCR-ABL response? This was actually assessed by the MD Anderson group, where they looked at the impact of complete molecular response on the survival. So they looked at all the patients who had received hyper-CVAD plus TK. So there were patients who had received imatinib, there were patients who had received nilotinib, there were patients who had received dasatinib. And what they looked at was how many patients had achieved CMR. CMR. So CMR is basically BCR-ABL transcript percentage of less than 0.01%. So what they found is that if we look at the molecular response at CR, as in once the patient achieves CR, only 34% achieve CMR. but at 3 months, almost 60% achieve CMR. And one important point to keep in mind is none of these patients underwent transplant. So if you look at this particular curve, this actually looks at the survival of the patients based on the achievement of CMR, MMR, and no MMR. If the patient had achieved CMR at 3 months, the 4-year OS rate was 66% in comparison to 43% in the patients who had achieved MMR at 3 months, 32% in patients who had not achieved MMR. So why is this result important is because none of these patients underwent transplant. So amongst the patients who did not undergo transplant, if the patients achieved CMR at 3 months, they had an OS, 4-year OS of 66%, even without undergoing transplant. So this is a very important finding. So this was actually used by the Jimema group to plan for a response adapted therapy. So if we see patients were given steroid pre-treatment, then dasatinib plus steroid, and then they tried to do a response evaluation. If the patient had achieved complete molecular response, they had completely avoided giving transplant or even chemotherapy, and they had given only dasatinib. If the patient had not achieved CMR, patients were considered eligible for allo transplant. So they either underwent transplant or they got chemotherapy. So the patients who had achieved CMR had a 5-year survival of 70%, and the patients who did not achieve CMR had a survival of 52.9%. Again, underlining the statement which I had made before about the importance of achieving this particular molecular target. So achievement of CMR becomes an important goal in this patient. Now, does the chemotherapy backbone impact the achievement of CMR? Yes, it does. So, if you see the intensive chemotherapy plus TKI backbone, the CMR rates are much higher than the CMR rates seen in the low-dose chemotherapy plus TKI arm and steroid plus TKI treatment approaches. So both the intensive chemotherapy as well as the TKI type plays its role. So if we give intensive chemotherapy and use a third generation TKI, we are getting a CMR rate of almost 86%. And that has actually resulted in the decreased utilization of or decreased allotransplant rate in the later trials which are mentioned over here. If you see ponatinib trial, that is the hyper-CVAD plus ponatinib trial published from MD Anderson, only 21% had actually undergone transplant. Whereas this particular trial, which is the ECOG trial, the MRC trial, 72% underwent transplant. So, if we modify the treatment outline after a TKI chemotherapy backbone, if the patient achieves CR, what we need to look at is whether the patient has achieved complete molecular response or not at 3 months. If the patient has achieved complete molecular response at 3 months, TKI plus chemotherapy should be continued, followed by TKI maintenance. So we can actually avoid allogeneic stem cell transplant in this group of patients. And if the patient has not achieved CMR at 3 months, then allogeneic stem cell transplant will be the standard of care. Now, I have mentioned about the different treatment approaches in these patients. Now, where does the role of transplant come with all this data which I have presented? Now, the role of transplant was actually established even before the TKI era. 2 major trials had looked at it. So the first is the LALA 94 trial, where they found that if the patient has a sibling allogenic donor, they had a better remission duration. The patients with a donor had a 3-year OS of 37%. Similarly, the UKLL trial, its first cohort, which was done during the pre-TKI era, the patients who had a donor had a 3-year OS of 34%. With the introduction of imatinib, they did the second arm of the UKLL trial, where again what they found is that the OS had actually improved in comparison to pre-imatinib era. So as I had mentioned before, the imatinib was found to facilitate more transplants. And the question which arises over here is, imatinib does improve the survival. It does take the patient towards allo-HCT. Now, if we try to avoid doing transplant in the patients who had received imatinib, what happens? So this was the patients who had not undergone transplant. What was found is that the patients who had received patients in the imatinib arm had a 4-year survival of only 21%, which was almost comparable to 16%. So use of imatinib did not prevented the need for allogeneic stem cell transplant. But all this data which I have presented till now has come from the first generation TKI era. The second generation TKI, that is dasatinib, nilotinib, and ponatinib, there are no trials which have looked at the randomized trial which have looked at the role of allogenic stem cell transplant. However, the trials which have been conducted later on have actually gone in for a response adapted approach, because of which the general approach has been to use general approach has been to use allogenic transplant in patients who are MRD positive. See, the other question which comes up is, in patients who undergone allogenic stem cell transplant, is the role of TKI post allogenic stem cell transplant. So that has also been assessed. That has also been assessed by the GMAL group, who looked at the role of prophylactic imatinib versus MRD triggered imatinib, and what was found is that an MRD triggered approach would be preferred. So even in TMH, we use an MRD triggered approach, where post allogenic stem cell transplant, we monitor the RQ-PCR monthly, and then imatinib is started once the patient becomes MRD positive. So the conclusion is that allogenic stem cell transplant is not dispensable even in the era of newer TKs. If the patient is not able to achieve MRD negativity, then allogenic stem cell transplant should be offered to the patients. Now, the recent 3-4 years, we have also noticed the role of newer agents in the treatment of Ph positive ALL. So there have been 2 trials which have looked into it. One is the dasatinib blinatumomab combination. Here, this was a phase 2 trial which was published by the Jimima group, where they gave 84 days of dasatinib plus steroid, and then from day 85 onwards, they added blinatumomab. And what was found is that the overall survival was 95%, and the DFS was 89%. So this was a completely chemotherapy free regimen, and this resulted in such excellent 2-year OS and 2-year DFS. This was a abstract which was published in the ASCO 2021 meeting, where they used ponatinib and blinatumomab in patients with Ph positive ALL, again a phase 2 trial, and we are finding excellent results in the form of 100% 1-year EFS and 100% 1-year OS. The CMR rates are 85%. So, in conclusion, Ph positive ALL is a high risk disease. With the introduction of TKI, the outcomes have improved over the last 2 decades. Uh, 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 Three approaches can be used: intensive chemotherapy plus TKI approach, low dose chemotherapy plus TKI approach, steroid plus TKI approach. The intensive chemotherapy plus TKI approach results in better depth of response than the other two approaches. However, with the risk of more treatment related toxicity, assessment of molecular response becomes important in these patients. Achievement of MRD negativity can actually avoid allogeneic stem cell transplant in a subgroup of patients. And newer agents are actually paving a way for chemotherapy-free treatment. Chemotherapy-free treatment, and the coming years would be we would be able to know how the treatment changes with these agents. So I have not covered the relapsed Ph positive ALL in the PPT because already this was too big. Thank you. First question which was asked is, are we doing MRD assessment and monitoring in routine care? Yes, ma'am, we are doing MRD assessment for all our patients. After first month of chemotherapy plus TK, we do MRD with MRD assessment with flow cytometry, and then along with the MRD with RQ PCR. And then subsequently it is monitored at the end of each consolidation phase, and then every 3 months. Second question is, flow MRD positive after phase 2 and CMR at 3 months, do we suggest transplant? How common do we see this scenario? So flow MRD positivity after phase 2 and CMR at 3 months. This is not a very common scenario. When it comes to flow MRD, when there is a discordancy between flow MRD and CMR, the molecular response should be considered. Ma'am or sir, can you? Yes, sir.
Yeah. So what Vasu is asking is that the flow MRD is positive after the phase 2 of induction, and the patient attained a complete molecular response at 3 months. So the conclusion that 3 months CMR the transplant can be avoided is it's an evolving question. It is not yet settled. So the data that you have shown, the paper from MD Anderson group where they have used dasatinib with hypercivat. So if they themselves have admitted that the outcomes were too far better from their historic data of TKI with hypercivat, and if you see the median WBC count in in that MD Anderson paper was 9,000, 10,000. That was the median WBC count. So it is a small study with excellent outcome without transplant. Those who achieved a 3-month molecular response. But if you see the guidelines, be it ASBMT or SPALSA, they still recommend transplant for adults, irrespective of the molecular response. And second is now the discrepancy of molecular response and MRD. Now, so there is a data from again SFAL group, is that the transcript MRD is very sensitive, and when you compare the MRD of IGTCR, flow, and molecular, the IGTCR and flow MRD has very good concordance, and the predictive capability of prognostic relevance is definitely excellent. Now, if you see a lot of molecular MRD positivity, even if they are IGTCR negative or flow negative. So now, if I have to give significant, or you have to give a leverage to one of the MRD, then I will give more to the flow MRD rather than the transcript MRD. No, because in the SPAL data, they found that molecular MRD has a better predictor other than a flow MRD. So we don't have IGTCR. European group use IGTCR MRD, but what we use is flow MRD. And if flow MRD is positive after phase 2, so these patients definitely don't do very well, and the chances of relapse is very high. So even if they achieve a CMR at 3 months, transplant will be a standard of care in these patients. I will invite maybe Madam or anybody from the transplant unit, maybe Anand sir or Sachin sir can comment on this.
So just to add to what Vasu has asked, the situation that you have flow MRD positive and CMR at 3 months, it's usually very uncommon. So if you see, it's predominantly molecular MRD which persists in these patients, and they don't achieve MRD negativity from the PCR point of view if you're looking at BCR-ABL transcript here. So that's an uncommon scenario. And if you look at even the data where they have looked at the CMR at different time points, whether you're talking about day 23, whether you're talking about day 45, and then you're looking at 3 months, that's at 90 days. So at earlier time points, you do have molecular MRD positive, and the number increases. So depending on what regimen you have used, it can be anywhere from 15% to 60%, depending on what type of TKI you've used. The rates of MRD negativity at earlier time point can be variable. So having the first situation that flow MRD positive at phase 2 and CMR at 3 months, the discrepancy is more in the molecular MRD rather than flow MRD. So that's one point. So it's an odd situation. And second, having said that, let's say even if the flow MRD is positive and you get at 90 days CMR, what's your flow MRD at this time point? So if your flow MRD has also become negative and you have complete molecular response at this time point, I think they will do similar to what other CMRs at 3 months are going to behave. So that's one. Second, I agree with Lingaraj that in adults, even if you get CMR, so we are talking about the adults are two kinds of adults where you are looking at high risk of transplant related mortality. And the kind of match what you have. So if you have high risk of transplant related mortality, then if you have CMR, you can safely think of not going ahead with transplant, and you can just closely monitor and continue with your rest of chemotherapy along with TKI. But if you have a patient who's otherwise fit, you can who's otherwise fit, and you have a fully matched HLA sibling, then in that case you should think of transplant. The only exception probably is the patients who are young in the terms of AYA age group, where the data of pediatric setting that if you have CMR, then you can omit transplant in these. So the two extremes, younger individuals or those who have, high risk of treatment-related mortality with transplant, you would avoid if they get into CMR. For rest, the data, as most of these studies are limited to small numbers, so the data still remains that you should think in terms of transplant if feasible.
And Akhil, if you see the graph study, that you have shown, the reduced intensity induction versus full intensity hypercived, where transplant was done in both the arms, and if you see the multivariate, hyperleukocytosis, like more than 30,000 baseline WBC count, was an independent predictive factor of benefit of transplant. If you see that paper, it's in the supplementary. So why I raise that point is that whenever you see the Western data, you should see the baseline count, what was the presenting count. In our patient, you see the counts we see is in lakhs, in Ph positive ALL. And if you see the Western paper, the baseline TLC that I mentioned in that MD Anderson paper is 9,000. So definitely the patient population is different. So when you kind of compare those data, you should see the baseline factors to come to a conclusion. So anyway, the randomized study will answer always in a better way, but it's difficult to get randomized studies. So definitely you have to rely on data and cross comparison of various studies. Jaya madam has asked any question. Akhil, can you answer that?
Yeah. Flow for pH positive HLA has some myeloid markers. Does the peripheral smear also show immature myeloid cells? No, ma'am. Actually, peripheral smear does not show immature myeloid cells. That flow myeloid markers are the character of the uh, uh, blasts which are seen. So that is all. So immature myeloid cells are not seen. Do we screen for pH positivity in BAL only or in TAL also? Is presence of B cell marker essential for the diagnosis? Yeah, so pH positivity we will be screening in BALL and also in MPAL. TALL we need not check for pH positivity. For diagnosis of pH positive BALL, yes, presence of B cell markers is essential.
I think there are no further questions, so I will hand over to Kumar sir for the proceedings.